Good morning for this edition of GISE. For me, it's a pleasure to be here with Dr. Bonaca, which is one of the master in therapy and intervention. And we want to talk about the therapies that are necessary for our patient to treat both acute coronary syndrome, but even chronic coronary syndromes. So not only to speak about the devices, but medical therapy is very important. What about the new and the future of these therapies?
Well, it's wonderful to be here. It's a wonderful Congress, and we had some cases this morning talking about the latest interventions and devices, and I do think your point about how do we optimize patient outcomes really is the pharmaco-invasive approach, the best intervention coupled with the best early and late medical therapies to reduce risk. And I think on the horizon we have newer ways of thinning the blood, so factor 11 inhibition has been in the news, or as well as novel ways of marrying antiplatelets with anticoagulants, but then lipid modifying, not just LDL but LP(a). And so I think there are a number of medical therapies that will hold promise for our patients, but it's going to make our job harder in terms of what to give to who and when.
Thank you very much.
Yeah, fantastic topic. Well, you have been busy with trials, looking at tackling the vulnerable plaque using PCSK9. I mean, how do we need to treat patients? Do we need to tackle the vulnerable plaque or the vulnerable patients? That's a tricky question, I know.
It's a great question. I think the answer is probably both. That as we learn more about plaque biology and how to tailor our interventions, understanding which plaque to treat and how to treat it will be very important, but that we can't distinguish that then from the patient, where we need systemic therapies to reduce risk. And I think that how we combine those two things is really important. So we have a new trial starting called Evolve, which is the notion in the acute coronary syndrome patient of revascularization and then just giving a PCSK9 inhibitor no matter what the LDL is, no matter whether, even on top of optimized statin, because then we know we can stabilize plaques even outside of the intervention.
And talking about, for example, complete revascularization in acute coronary syndrome patients, we have learned that we have to achieve complete revascularization. On the other hand, when to treat the non-culprit lesion, how to treat it, and probably actually optimizing medical therapy before getting into the revascularization. What are your thoughts? What's your view about that?
Well, it's a great question. Actually, this morning's session with the editors, the discussion of, do we treat ischemia or not for chronic coronary syndrome, and then that in contrast to the very compelling data for acute coronary syndrome, where complete revascularization clearly is beneficial. And it really tells you that there's something different about the plaque biology and the patient vulnerability there. Yeah. And I think in the patient who presents with an acute coronary syndrome, they're fundamentally different, and the plaque biology is different, and we have to be very aggressive. I think both with revascularization, but also systemic therapies to dramatically lower LDL, antithrombotic therapies, and other approaches in that patient population.
And in my point of view, actually, it matches the direction that on one hand, we are trying to shorten the DAPT, because probably that's the goal for both stable and acute coronary syndrome patients. But on the other hand, we are trying to optimize the rest of the medical therapy. So probably complementing the two, we are getting into like a lower bleeding risk and better prevention of ischemic events. Is that my optimistic idea, or?
Yeah, well, I think it's a great question and always a topic of debate,
Yeah.
The short versus long DAPT. And of course, even with dual pathway, I mean, the issue is always bleeding and long-term risk of bleeding, and we know that our patients, their bleeding risk never really goes down. I mean, as they age and they develop other comorbidities. So I think your point's an excellent one. One part of it is if you can reduce the risk through other mechanisms, maybe you can shorten DAPT. Another part of it may be that, what monotherapy you select may be important. So maybe P2Y12 is particularly important. And then on the horizon, we have novel agents like the factor 11 agents that
Correct.
hold promise. And after ESC, I think there's some debate about how and what doses, but still, they hold promise for addressing thrombotic risk and decoupling that
Yeah.
from bleeding risk.
Yeah, yeah.
So very, very important observation. You highlighted that it's important to treat the patient, but even to prevent future events. This it will be the future of our job. And what about, in your opinion, talking and thinking in a future where a drug will be the most therapy, the most important therapy, instead the devices, because we are moving now with using newer device, disappearing device. So the future it will be medical therapy.
Well, it really it's a provocative question. I think if you took this to an extreme and you thought about primordial prevention, there are probably many procedures that would never be necessary if we acted early enough and intensely enough. And so, on the horizon are gene editing therapies to dramatically lower cholesterol that one could get in their 20s, and that perhaps you wouldn't need a coronary or peripheral intervention down the road. Now, there are other diseases like degeneration of the mitral valve where maybe that it's a different issue and it may be hard to prevent if we live longer. So I think it's a combination of both, but I do think more intensive, more tailored medical therapy might delay at least the need for procedures, but I think the evolution in technology is so exciting to be able to do more tailored procedures, longer term outcomes, and better technologies with lower comorbidity. So the future is probably both, but I hope we can prevent many of these. For peripheral artery disease, I often think of it as a totally preventable disease. If we could prevent smoking, diabetes, and lower LDL cholesterol very low, we probably wouldn't have that problem.
Thank you. So treating, but most importantly, prevent the disease. Okay.
Yeah.
Thank you very much, and see you the next year.
Yeah,
Thank you. Yes,
exactly.
absolutely.
Thank you very
Yeah,
much.
thank
See
you.
you. Bye.
Goodbye.